This man is on the intensive care unit, ICU. He's sedated. The ventilator is doing all of his breathing for him. He needs drugs to support his heart and his blood pressure. And if he is without them for 30 seconds, his heart will stop. The dialysis machine is doing the job of his kidneys. He is dependent on us for his nutrition, his bladder, and his bowel care. We have to wash him. We have to brush his teeth. We have to turn him every few hours to avoid pressure sores. And we watch his parameters constantly, every heartbeat, every breath. But if we do not diagnose the problem which has made this man so sick, none of these machines will help him. This is intensive care. Let me take you back to February 2020. COVID-19, a virus which at its peak would claim the lives of 1,800 people per day in the UK, was about to arrive at our shores, and the UK was totally unprepared. Not only does the UK have one of the lowest number of ICU beds in Europe, 6 per 100,000 population, 1/5 that of Germany, which has 30 per 100,000 population. But 80% of England's 4,000 ICU beds are already occupied. Staff preparedness is almost non-existent, and the lessons of recent government pandemic exercises designed to prepare the NHS and protect its patients have not resulted in a change to our healthcare establishments. In Bath, we are ahead of the curve. We have converted an entire operating suite into a second ICU. We're about to get approval to build a third ICU, ultimately built in a staggering 42 days, giving us a 5-fold increase in ICU capacity in Bath. We're training our staff how to use personal protective equipment to prepare themselves, but we cannot take away their fear. Everyone is scared. Scared of the fate that may befall them through coming to work and doing their jobs, scared that they may take the illness home to their families. Coming to work in March 2020 was, for all frontline healthcare staff, an act of bravery. The UK modelling is published on the 16th of March 2020. Demand for ICU will outstrip supply 50 to 100 times over, and the country faces the very real prospect of being unable to provide intensive care to all who need it. It felt apocalyptic. This is Gavin. He's 64, husband to Julie, and father to Connie, Georgia, and Hannah. On the 3rd of April at 16:23, he makes one of the hardest phone calls of his life. He calls his wife to tell her that he has COVID-19, he is critically ill, and he is about to be anaesthetized and put on a ventilator, life support. They know that this is the last time that they may speak, and as visiting is not allowed, they may have seen each other alive for the last time. As Gavin is anaesthetized, he surrenders himself into our hands and into the great unknown. Unknown for him and his family, but unknown for us too, because this was a disease unlike anything we'd seen before in intensive care. It presents differently. The blood tests look different. The scans look different. It endangers the staff, and it is more deadly. Even today, somebody who needs a ventilator for COVID has a mortality of 40%, double that of other viral pneumonias. So how did we learn to treat patients with a condition we knew nothing about? Well, uncertainty forms part of my job. There is uncertainty over diagnosing and treating patients who are already so sick. And with COVID, we had to use that experience of managing uncertainty, but also our mental model of managing similar conditions. However, finding out where that mental model proved to be wrong and learning how to adapt it required collaboration and sharing locally, regionally, and nationally across our healthcare service. Let me give you some examples. Patients would arrive in hospital with very, very low oxygen levels and devastating lung injury. Here you can see a CT scan from a healthy patient. You can see the lungs are black because they're healthy and they're well aerated. Here you can see a scan of a patient, one of our patients with COVID. You can see that the lungs are white because they're infected, they're inflamed, and there's virtually no healthy black aerated lung. We learned quite quickly that we could improve some patients by turning them, whilst they were sedated and on the ventilator, onto their front. Now, this is something we've been doing for many years for other conditions, but now we needed a whole team of 6 people dedicated to turning multiple patients back and forth for several days in a row. This was life-saving. These lungs needed a totally different approach to ventilation. We had to throw out conventional practice, and we had to learn how best to use the ventilator by continually adjusting it at the bedside and discovering which maneuvers would improve oxygen levels and which wouldn't. And we discussed these in consultant meetings, and we learned from one another locally quite quickly. But for some things, we had to pool our learning because it was impossible to know if what we were seeing was individual patient variation or a pattern emerging in a new disease. For example, discovering that patients had a tremendous tendency to form blood clots in the lungs, in the brain, in the gut, in the dialysis machine, causing it to clot and stop working, required collaboration from intensivists like myself and hematologists, blood experts from across our region. And identifying this and agreeing what to do was vital because in those early days, patients were dying of blood clots or suffering serious consequences from them. The regional collaboration was also where we learned about our next vital drug, equipment, or consumable shortage. And it allowed us to plan for the care of patients before the shelf was empty. Then, of course, there was collaboration at a national level, something that the UK, with its National Health Service and national professional bodies, was in a unique position to benefit from. There were several national webinars broadcast to ICUs across the country where experiential learning from units who'd seen a lot of patients was shared. And this represented a fundamental change in our understanding of how to manage the disease. We learnt that in attempts to rescue or improve the lungs, some patients had worsening kidney function. And in the context of an international shortage of dialysis fluid and dialysis equipment, this was vital information. But none of this is evidence-based medicine. It feels very uncomfortable because the balance of risks and benefits is untested, and the margin for error when patients are already so sick was tiny. It was life and death. We needed formal research trials, and this was another area where national collaboration proved vital. Despite the incredible pressures of delivering intensive care in the midst of a pandemic, national research trials began in earnest in March 2020, and the results, which became available from June 2020, influenced the care of the sickest patients in the UK overnight. We are all indebted to the patients and researchers for generating this invaluable evidence. And so, with these trials, with this evidence, our understanding of how to manage the disease shifted from experiential learning with sharing of events and adaptation to a scientific, evidence-based approach of how to manage the disease. But these successes are dulled by our failures as a nation. Our nationwide lack of ICU beds and staff and the limitations in our healthcare infrastructure have levied a heavy cost on our generation. What's more, our staff are left exhausted after 20 grueling months of work, and ICUs up and down the country are today operating at 80 to 180% pre-pandemic levels of capacity. And what of Gavin? Gavin arrived when we were on the very steep part of this learning curve. He developed a clot causing a stroke. He had life-threatening problems with his abdomen, and he was still on a ventilator 4 weeks after his admission to ICU. And prior to the pandemic, our median length of ICU stay was 4 days. And so there were multiple times when we thought he was not going to make it. And for his family, to hear this by phone as they couldn't visit was an extreme form of anguish that I think few of us can really understand. But 34 days later, he was well enough to be discharged to the ward, and he's now at home with his family, and he's going to walk his daughter down the aisle next year. There's no magic bullet for patients who are sick enough to come to ICU, and there's no magic bullet for patients with COVID on ICU. Progressing the care that we can deliver requires the aggregation of marginal gains. Many of our gains in this pandemic were achieved because our country has national channels of communication for information sharing and for the rapid enactment of research. We changed what we did for Gavin within hours of his arrival, and he is a living example of the success of local, regional, and national collaboration and sharing within the NHS. This pandemic is not over, and there will be others. We have to remember the incredible way in which we have shared, collaborated, and adapted, but also where we have struggled and where, as a nation, we must never fail again. These lessons must drive healthcare evolution, such as a much-needed expansion in ICU capacity across the country, so that we can look after our patients of today, tomorrow, and those of future generations. Failure to do so will dishonor our patients of this pandemic, such as Gavin and those who have been less fortunate than him, but also our staff who have given and who continue to give so much. I'd just like to take this opportunity to thank all of our amazing staff at the RUH, especially our matron who's here this evening, and all of you for your incredible support. Thank you.